All right, thank you all for joining us for this Disability Health Committee Public Forum. Good morning. My name is Liam Daquerny. My pronouns are he, him. I am a 30-something male with shaggy brown hair. Yeah, thank you all for being here. We have this meeting sort of as a back and forth to update the disability community on the condition of COVID, everything COVID in the city, and hopefully disability sort of policy and awareness of health in the future. But now we are focusing on COVID, and if you can hear my cat Rico in the background, please ignore him. I am admitting a few more people, and then we are going to get started. I will pass it over to Emily Fry. And as a note, if you could just keep your Zoom on mute while we go through. And if you'd like, it would be better accessibility-wise to type your questions in the chat. Of course, if you're unable to do this, raise your hand and we can circle with you, and we can take those questions on a rolling basis. And yeah, thank you so much for joining us. And over to Emily.
Liam, could you make me able to share my screen?
All right, you should be good now.
Okay, give me a signal, everything's good. Hear me, you can see my screen. All right, thanks, Liam. As I was introduced, my name is Emily Fry. I work for the Department of Public Health in Philadelphia. I am here as a part of the Division of COVID Containment. So that's really my specialty. A little bit about who I am. So I'm a nurse. I have a master's degree in nursing. I use she, her pronouns. My nursing experience is in mostly pediatrics. I worked at CHOP for a number of years before discovering this position. I'm a West Philadelphia resident, but I've lived kind of all over the city. Personally, I'm a mom of a 3-year-old and I'm very pregnant right now, so bear with me. And just as a note, I have a visual impairment. It causes me to tilt my head. And as you see, I kind of talk out of the side of my eyes sometimes. But that's not because I'm not looking at you or paying attention. It's part of the disability. I also wanted to note that I often use words like impairment, disability. If those are not inclusive words for you, I apologize. It's just how I've learned to talk about my own differences. So during this presentation, I really wanted to just give you guys an update about how COVID-19 is going, specific to Omicron, talking about vaccines and treatment options, and of course, barriers to receiving care or information. I very much encourage participation. I have two colleagues on the chat, Josh and Mia, who might be helping me answer questions or chiming in here or there. They are also clinicians on my team. So the new hot thing about COVID is talking about where are we going from here? Everybody's wondering if, if this is on a downswing or if we're going to have another variant pop up. And a lot of vocabulary is being used. I really like this visual. I can describe it to you. So this is talking about what an endemic disease is, an epidemic disease is, and a pandemic disease. The first picture is of a map, and it has a few dots throughout the whole map, which represent areas where a disease is present, and that's describing endemic disease. That means that it's present in a population. It has very predictable spread. This would be like your common cold, right? We know it's out there. We know you can get it. And we know pretty well how it behaves. Just a regular old like cold. An epidemic in the second picture is a map, and there is a cluster of dots on one continent in one area. And this represents epidemic disease. It's an increase of cases spreading through a large population. So it isn't the whole world. It's a specific place where maybe you see an unexpected outbreak of a disease, or let's say, a lot of people use HIV/AIDS epidemic as an example of this. And then the last picture is pandemic disease, and there's lots of dots throughout the whole globe. And that is COVID. Sudden increase of cases across several countries, areas all over the world. So those are kind of the three classifications of diseases. So to be in an endemic phase, which is a lot of people's goals with COVID-19, is we would have to have predictable spread. So, we wouldn't be surprised anymore. A background level of disease that's manageable, that doesn't cause, hospitalizations to overflow, or, public health to be overstretched. Just thinking about kind of where we are right now with COVID, we're not ready to make that call that it's endemic. We're relatively close to when Omicron started, and we were very surprised by Omicron in, just the different ways that it behaves. So we need to be in a more predictable time to call it an endemic. Omicron and other variants. So, I know that everybody probably has a different level of understanding of viruses and COVID, because of course we've been living this for the last 2 years. So I'm sure you've heard of variants. Variants are expected and a normal outcome of spreading virus. But when we have a lot of replicating, so the virus is spreading very quickly, there's more opportunity for mistakes to be made that tweak the virus just a tiny bit. And over time, those mutations collect, and then we have this variant. The important thing about variants is that the less the virus spreads, the less variants occur. So Omicron is one of those variants. We have several categories of variants in the United States. What I think is important is that variants can be classified differently in different places. So the World Health Organization looks at the whole Earth, right, and what's going on globally. The CDC looks just at the United States. So if there's another variant going on in another part of the world, it might not necessarily be a concern for us. So right now, I think the important kind of categories to focus on is this variant of concern, which is a variant that shows us that it behaves differently, and it can be concerning. And that's where Omicron is and Delta was and still is classified as variant of concern. A variant of high consequence would be above that. So that would be a variant that we have problems tracking. We have really problems treating. Our vaccines are not effective. This would be a very bad consequence of continued spread of the disease. So the US doesn't only track those variants that are concerning to us. The CDC also tracks all variants that are different from the original strain and monitor them. So if you remember way back when, alpha and beta seems like a different time, but those are always monitored. Excuse me. So there's a lot of questions about how Omicron behaves differently. And I wish I had, all the information and could answer all of the questions. But believe it or not, Omicron just came up a couple months ago. It seems like forever, but we're still collecting data. Omicron is the dominant variant in the US, so pretty much anybody who gets COVID now has Omicron. Symptoms are very similar to other variants. We're of course looking at, every aspect of how it presents. It's generally less severe disease. But what I think is really important to remember is that even if less people are hospitalized or die from Omicron than other variants, the transmission is so high that we can still have a high level of people getting very sick. There's studies coming out every day about the effectiveness of the vaccines, and pinning down the exact number of how effective it is against Omicron is still being determined. But it's very clear that vaccination is better than no vaccination. And that you're more protected from hospitalization and severe disease if you are vaccinated than unvaccinated, even if you get COVID. So how is COVID doing in Philadelphia? I have family that lives in other parts of the country, and their COVID world looks a lot different than my COVID world. So I like to look at Philadelphia, but I also like to think about other parts of the country. And, you know, there's just so much information out there that I have to take a step back and be like, well, this is Philadelphia, what's going on here? So case rates in Philadelphia. On this slide is a graph that I really like. I'm like a very clear visual learner. And I need to see what's going on as well as hear and read what's going on. So this graph is the percent positivity. So that means out of all the people that got tested, how many came back positive? And what's that percentage? I think it's a good way to look at data. So, and this graph starts in March of 2020 and goes all the way to where we are now, which is March of 2022. So you can see in the beginning of COVID 2 years ago, there was a peak to almost, you know, to like 35-ish% positivity. So a lot of people who were getting tested were coming up positive. And then, you know, we went through our lulls and our peaks, and then Omicron hit, and starting in January, we have very, very sharp spike above 40% positivity. So that means that out of all the people testing, that 40% of them, so 4 out of every 10 people that got tested were positive. And now what is nice to see is that it sharply took a turn and came right back down. And now we're in the 1 to 2% positivity. And let me tell you, if you asked me if we could get there a month ago, I would say, I don't think anytime in the future, but, you know, Omicron proved me wrong, as I said, not as predictable as, you know, we would like, but that's a really good thing for us right now. This is more data for Philadelphia. And this is, the lines are by age group and they're kind of hard to see, but I like to look at the overall trends. The first one on the top left is testing. And when I like to see a lot of people getting tested, for me, because that means that testing is available. And right now it is going down a little bit. We're going down on the trend of testing. And I think that's because of 2 reasons. One, we know that it's been very difficult to get tests. And 2, as Omicron is less prevalent, people will feel less compelled to get tested over and over again. In the next graph on the top right is infections. And that's the same kind of graph I just showed you from the last slide. We can see it's not in percentages, it's in raw numbers, but we had that big spike with Omicron and we're going down again. And that's with all age groups. The bottom left is hospitalizations. So hospitalizations tend to be a few weeks behind actual positive cases. So if you think about it, you know, somebody gets sick, they, you know, try to fight it at home, you get sicker and sicker and sicker. You may have tested it when you first had symptoms, And then, you know, a couple of weeks later, you get so sick you have to go to the hospital. And we're seeing those rates go down as well. Hospitalizations, as we know, and severe outcomes are more common in the older than 75 age group, and kind of goes down from there by age group. And then deaths as well. In the last graph on the bottom right, I think this is helpful to see that in the beginning of COVID, there were a lot of deaths. And even though now in, you know, March of 2022, we are having this huge spike. We had this huge spike in infections and hospitalizations. We certainly had a spike in deaths, but not as high proportionally. And I think that's really because we've learned so much about how to manage COVID, and we have vaccines that, you know, we're able to treat people better and have better outcomes. And then this is the whole US. So I like to show this variant breakdown because I think it's interesting mostly. But I like to see that, I like to see how COVID has been changing over time. And in this graph, towards, you know, this starts November of 2021. All this orange over here, and I can tell you that it was almost at 100%, was Delta, if everybody remembers Delta. And so quickly did this purple, which is Omicron, take over. What I also think is important to note is that we see with Omicron, we have BA 1.1, B 1.1529, BA2. And, you know, it's been sporadically in the news that there are kind of cousins or relatives of this variant. Right now, that's not concerning to us. We're tracking it and we're seeing how they behave, and obviously, like, we're differentiating between the different kinds of Omicron, but they're all Omicron. They all behave like Omicron, as we've seen, and it's very, very common for variants to have kind of offshoots. It might mean just one little genetic piece of genetic code is a little different. So I'm going to talk about Philadelphia's response. So a couple weeks ago, the health commissioner announced that we are going through this tiered level approach to help us decide what kind of mitigation we need. So if we need to all stay inside, if we need to all wear masks, if we should be, you know, if gatherings should be canceled, things like that. And I'm just going to outline them quickly. So the highest level of response would be extreme caution. And we would be in that level if we were having a high average new cases per day, if hospitalizations were more than 500, if percent positivity, so that number that I showed went up to like 40 and went back down to like 1, if it was above 10, we would be looking at this level. And if cases had risen by more than 50% in the previous 10 days. So that would be like at the beginning of Omicron, when things were just like doubling and doubling and doubling and doubling, that would be, we would say, okay, we got to look at this. If we were in extreme caution, we would require that the public presents proof of vaccination to eat indoors and wear masks while in indoor public places. So we were really just there. And then kind of a middle area would be caution level response. So we would be at that level if we had, you know, a higher average new cases per day, but it was less than 500. Our hospitalization were just under 500. Our percent positivity was just under 10%, and that cases hadn't risen. So this would be a time where we would be wary, but we would see that we weren't at a level that was such high transmission that we needed to be very separated. This would mean that you would have to present proof that you're fully vaccinated or a negative test to eat indoors, and you would need to wear your mask in indoor public spaces. And then when the commissioner announced this tiered system, we were in this lower level of just mask precautions. That we were at average new cases per day were less than 225. Hospitalizations were under 100. Percent positivity would be under 5%. And that cases had not risen sharply. And I know these are a lot of numbers, and so I'm reading them out so you can hear them, but it's just kind of a comparison thing. It's not like a memorization thing. But when we were in mask precautions, which was last week, you would wear a mask while indoors at public spaces. So the newest announcement from the health commissioner was that we have reached an all clear level. So this level is where average new cases per day is less than 100. And I think we're at somewhere in the 80s. Hospitalizations are under 50. Percent positivity is under 2%. And I showed you and talked about in that graph of percent positivity, we're somewhere between 1% and 2% right now. And that cases have not risen by more than 50% in the previous 10 days. And we also can know that because of the sharp decline in cases that has happened since Omicron. So what does this mean? We're in all clear. Cool. That means that no COVID-19 mandates are enforced from PDPH. And that sounds really intense. What that really means is that you're not required to wear masks indoors. We're not, enforcing vaccination if you want to eat indoors, any of that things. What it does mean is employees still have to mask. So if your employer requires it, or if you're a healthcare worker, or if there's a federal mandate, like you have to, be vaccinated. It still means that we don't want you to throw your masks away. This doesn't mean the end of the pandemic. It means we reach these levels and, it could, we could have another variant. We could go back, but this is where we're in right now. But also, what also was announced during that time, if any of you guys have children or work in a school setting, that on the 9th, if everything continues to be good, that we will be lifting the mask mandate in schools. For those who are interested, it will be an interesting transition, and there will be more guidance that comes out later this week about what that will look like in schools. So one of the questions that I want to answer is about masking. So we've come, we're coming out of this and people are stopping to wear masks, but there's nothing that says that you can't wear a mask. I still wear a mask everywhere I go. It's a really personal choice where you're evaluating what feels comfortable to you. These two links are really helpful. They have information on how to care for your mask and what types of masks are available to use. I'll just talk about it a little bit. So the important thing with any kind of mask is if it's dirty, it's not working. So if it's a disposable mask, throw it out if it gets dirty or wet. Cloth masks should be laundered. And that's really like the most important thing, is keeping them clean. There are several types of masks that you can use. I should bring my masks up here so that I can show you. The cloth masks are, the ones that you wash. If you, if you wear a cloth mask and that's what you can tolerate, and that's what, nothing else works for you except for that one cloth mask, or like my 3-year-old, he wants a Spider-Man mask. Make sure that there's several levels of close knitted fabric. One test of this, if this works for you, is holding it up to the light and seeing how much light comes through it. And there should be very minimal. This is really not a recommended mask in the way that like a higher level of filtration and ones that are, monitored by organizations that look at how masks work. But a mask is better than no mask. The kind of higher level would be a surgical mask or a procedure mask. Those disposable masks, sometimes they're blue or yellow, or there's black ones out there. And those are ones that you would throw out after use. And that is a higher level of filtration. So that means that it filters out smaller and smaller particles. So if you don't know this about viruses, viruses are one of the very smallest particles you can have. So smaller than a dust, smaller than bacteria, smaller than smell particles. They're very small. So, the closer knit that mask is, the more filtration it will have. And then respirators is a category that we call all of those masks that are letters and numbers. So N95s, KN95s, KN94, KF90, all of them that have letters and numbers. They are respirators. And they are like hospital grade. Prior to COVID, we only wore them in the hospital when patients had things like tuberculosis. They are very highly filtered particles. They are somewhere around 95 to 98 usually percent. That's what we're calling like a high filtration, the percentage. And those are harder to get and obviously more expensive. They're meant to be disposable. What I say is keep it in a safe place. Paper bag works if you are reusing them. Don't reuse them if they get dirty or wet. And those are the most filtering and are the most highly recommended mask at this time. The important thing with that is to make sure that they are being advertised for what they are. So there are companies out there or individuals who are selling, not tested masks as respirators. If you ever have a question about your mask, you can call PDPH, you can call our COVID hotline, which I have the number in here. And we can help you sort out if it's if it's an adequate mask or not. So where are we now in Philadelphia? We're in a downswing from Omicron, yay. Mask mandates are lifted. Masking in schools are going to be lifted on the 9th if everything continues to go well, which it has. However, there's still a vaccine mandate for most employees within the city. That's up to the individual's employer. It's also all healthcare workers. It's also all teachers that work for the school district. And you can check in with your individual employer about that. All right, vaccine safety and efficacy. So this is my what's going on in Philadelphia. So if you're wondering, hey, I live in Philadelphia, what are the chances are I bump into somebody who's not fully vaccinated? And we're using fully vaccinated as have gotten either Johnson & Johnson or the 2-dose series of an mRNA vaccine. Oh, I have a question in the chat about the masking in schools. So masking in schools on the 9th, it will be a citywide policy. However, individual schools can choose to have, more strict recommendations. Or so, let's say your child's daycare decides that they want to keep masks. That's totally fine with us. They're not mandated through the city though. So we have been in discussions with a lot of schools throughout the city, but there have been no definitive policies that I know that have come out as far as like what all the charter schools want to do, what all the independent schools want to do. But stay tuned for that. Anyway, back to the fully vaccinated Philadelphians. So the percent of Philadelphians that are 18 and older that are fully vaccinated is 81.8% right now. The percentage for, have gotten 1 dose is higher than that. It's in the 90s. Percentage of 12 and older, so 12 years and older, who've got fully vaccinated is 75.7%. And that's pretty remarkable, I think. Obviously, we're still very much encouraging vaccinations, and we want more and more people to get vaccinated because of how effective it is. And then the bottom, it says residents who have received a booster dose. So 32.3% of Philadelphians 18 and older have received a booster dose. And I'll go over a little bit about booster doses and who can get them. Okay. So how do these vaccines work? Just quickly. So the vaccines, they kind of are recipes. So they send a message to your body to make antibodies that will help defend you against COVID in the future. None of the vaccines contain any live virus that could give you COVID. It's just simply a signal that says, hey, make antibodies that will fight off a virus that looks like this. How do we know that they're safe and effective? So I'm starting off here with like things that we don't know, right? We don't know how long the protection from the vaccine will last. Mostly because they haven't been in existence for that long. We do know that, boosters are helpful at the 5 or 6 month mark, but we don't know going forward what the recommendations will be for continued doses. The good thing is that the CDC is continuously collecting data. I think it's remarkable that this vaccine is pretty much the most scrutinized vaccine that's ever been in existence, right? Everybody's looking at it. Everybody wants to make sure it's safe. There's several monitoring and reporting systems for anything that would be out of the ordinary that either you or a provider would think is concerning. We have the VSafe program. There's been no relation to pregnancy issues, fertility issues. It does not interact with other medications, so you can safely get the COVID-19 vaccine, and there's not a whole lot of components that are known allergens. The COVID-19 vaccines are being held the same safety standards of all vaccines. There were large clinical trials, and what I like to point out is we've now had millions and just an incredible amount of doses that have been given. And I think real life data is better than laboratory data often. FDA's emergency use authorization, that's what gives us the ability to give these vaccines. And it's a very stringent process. The only reason why a vaccine doesn't get full authorization at that point is because it just hasn't been in existence long enough. So that's like the stopgap. But there are a few vaccines that have gotten full FDA approval. So Pfizer for ages 16 years and older has full FDA approval. Their brand name is Comirnaty. Try to say that a bunch of times. But the EUA still allows anybody older than 5 to get that vaccine. Moderna just got their full FDA approval for 18 years and older, called Spikevax. So anyone 5 years and older can receive a vaccine. We especially recommend it to people who work in high-risk settings, people with high-risk medical conditions, people who've had COVID-19, pregnant women, especially pregnant women. They have a higher risk of severe outcomes from COVID. The only real category that is like a no, don't get this vaccine is if you've had the first COVID-19 vaccine and you had a severe or immediate reaction to either that vaccine or a vaccine that had a same component. This is about boosters. So boosters, right now, you have this category of who should get a booster, and like we really have moved into this should get a booster category instead of when boosters first came out and it was kind of not, we weren't seeing the full effects of Omicron. It was a, it was a recommended or a, you were eligible. Now we're really in the should category. So anybody who is 12 years and older should get a Pfizer booster. They should have gotten Pfizer for their first one. They should get Pfizer. And at least 5 months after completing your primary series. With Moderna, anybody 18 or older, 5 months between your primary series and your booster. And then with Johnson & Johnson, we're saying adults 18 years and older, that's all that's approved for Johnson & Johnson. And you should get a booster at least 2 months after receiving your J&J. And we recommend that you get a booster with an mRNA vaccine. So there are some concerns for people with past medical conditions to take into account when they are choosing a booster. And we've heard a lot about myocarditis and pericarditis, especially in young men. This doesn't preclude you from getting additional vaccines. It just means that if you have this outcome after an mRNA vaccine, it's short-lived generally, and very well treated. You should defer receiving a subsequent dose, figure out with your healthcare provider what you should do. Autoimmune conditions, you can get any of the FDA approved vaccines, Guillain-Barré. If you have a history of it, you should avoid getting the Johnson & Johnson, but should discuss with your provider getting an mRNA vaccine. Bell's palsy, if you have a history of that, you can still get the vaccine. Those who use dermal fillers can get any vaccine. And then this TTS syndrome, which if you remember way back when the J&J vaccine came out, there were concerns for this. So women age 50 years and above should be made aware of the risk. People who should very much consider getting vaccinated and getting boosters are people with previous health conditions. So I have the link here to the CDC website because there's so many, and it's a really good kind of resource for you. But people who in general have history of heart conditions or at risk for heart conditions should definitely get all available doses for them. People with respiratory conditions. So if you are, on CPAP or BiPAP or vent dependent, or, have, when you do get sick, you end up, in the hospital for needing extra oxygen, things like that. That's a real concern. And then, what is always on the list of pre-existing medical conditions, obesity, kidney disease, liver disease, all of those guys. And if you want me to go through that, I can, but I feel like I want to get through this so I can answer questions.
Emily, if I could real fast. We actually only have the ASL interpreter until noon.
Okay.
We have some great questions in the chat.
Let's do
So
questions.
if we can be sure to circle it with them.
Sure. Let's do some questions. So Wendy says, at the beginning of the pandemic, People with disabilities were not prioritized for access to vaccines. What lesson has the city of Philadelphia learned and how can it be prevented in the future? I think we learned a lot from the rollout, especially because, you know, Philadelphia had a different way of rolling out the vaccine than Wisconsin did, then Maryland did, then Virginia did, and really taking a look at that data and comparing and contrasting how well we did with getting people access, and with, you know, did we prioritize the right people? I think that going forward even in the next year, but in the next 10 years, 20 years, the things that we're going to learn from this pandemic, and not just, you know, just pure scientific data, but what we've learned about people, how they react, how we can better serve our population is going to change a lot in the public health sector. Do any of my other colleagues have anything to add to this?
Hi, everyone. This is Mia. I'm one of the nurses here, colleagues with Emily. I think Emily answered this question good. One thing I do want to add, that learning during the height of COVID and the vaccine rollout, they were using that phase, and they were considering those who were at risk immediately, like healthcare providers. We wanted to make sure that they were protected so they can continue to protect and care for those patients who were sick with COVID-19. Since then, the health department has been exploring various options to reach the populations, or these hard to reach populations, or populations who cannot readily get up and come to a community site. With that being said, there was a program, I'm not sure in the status of it currently, but there was a program where the Homebound Program, where we would go. There was services for persons who had disabilities that restricted them from coming out the home. So they had nurses or healthcare providers going to the home to provide the COVID-19 vaccine. The status of that program right now, I'm not too sure about that, about if they're still doing it or to what capacity. But yeah, lessons learned. Now anyone who wants the vaccine or is eligible to receive it can get it. And if you have more questions about that Homebound vaccination program, if any of the community partners are questioning it or want it or want to partake in it, feel free to reach out to us via email, and we can see how we can arrange that. And please forgive me for talking super fast. I'm sorry. I don't know if Joshua Lewis is on the call, if he wants to chime in on that, or Betty Mulligetta, she is one of our outreach coordinators or specialists.
Hey, how you doing? This is Joshua Lewis, also a nurse that works with Emily and Mia. Then I just echo what Emily and Mia said.
I'm trying to get back to my Zoom, but it's not working. So we'll figure it out.
Emily, would you like for me to read the other question that's in the chat?
Yes, I'm putting back in the chat as well. I'm trying to paste a flyer into the chat that has to do with the Homebound program.
Thank you. So Cecilia Thomas asks, just for clarity, the March 9th, 2022 masking in the school is for the school district of Philadelphia. Does this
answer
apply?
That one?
Okay, you did answer that one. Okay.
Mm-hmm.
Let me see. Someone asked, if you received the booster, are you expected to get another one in a few months?
So as of now, we haven't planned on a widespread second booster regimen. I do know that there are some people that are eligible for a 4th dose at this time because they are also immunocompromised. So those who are immunocompromised get an additional dose in their primary series, or if they already received their primary series, they can get an additional dose, and then they would get a booster 6 months from that dose. Do you guys have any leads on that? On additional boosters?
No,
I do.
not this.
Yeah,
not
I do
this
not.
time.
Okay, we've all heard the same thing then. Sometimes you go to a specific meeting and somebody gets something else.
Yep.
But that's
Emily-
not to say that won't happen. It's just not announced yet whether that will or will not. Mia, did you have something to add?
I was going to say this might be a good time to explain why it's a quote unquote 4th dose, just to differentiate between the immunocompromised individuals. Their primary series is actually a 3-dose series. I don't know if you want to extrapolate on that a little bit, just so it can be like kind of a little bit more clear.
Why don't you do it while I'm trying to figure out this homebound thing?
So just to kind of just clarify, for those individuals who are considered to be moderately or severely immunocompromised, our research and the data that was collected showed that they do benefit from actually, instead of getting, like if it's an mRNA this is for mRNA vaccines, meaning the Moderna and the Pfizer vaccine, which are for your normal population, or not say normal, your regular or usual population, it's usually a 2-dose series. But studies and research and data has found that those who are immunocompromised benefit from getting a 3rd dose, or making their primary series 3 doses. So when Emily was talking about the 4th dose, that is their additional, or their booster, or quote unquote, if you want to call it a booster dose, after they're done their primary series, which is a 3-dose series. I hope I didn't make that confusing. Did I get that right, Emily?
You got that right. Are there any questions that are not put in the chat right now?
I just want to chime in about the Homebound program. I'm having trouble posting the flyer in the chat, but call 311 or 215-685-5488 and press 5 for interpretation services, or obviously dial 711 for TRS TTY assistance, or we have the URL bit.ly/homebound vaccine PHL for more information. And you can definitely email me if you do not have this flyer. I'll be sure that it goes out to everyone possible. And
Yeah. I put that in the chat, the phone number for PDPH for the COVID containment division, and the email. And please, they are wonderful people that answer the call center. They would love to help you.
Thank you, Emily.
I did post a link to the in the chat for the homebound vaccination program, as well as the red cap appointment. If you need an appointment, you go right to that link and fill out for an appointment. They do have appointments available to that.
As far as resources go, I don't know if you guys are aware that there are you can get free masks, free respirators from several community pharmacies, mostly the big retail pharmacies, but also other pharmacies within the city. I know that some of my wonderful colleagues have popped into their local CVS or Walgreens and asked, and they will give them to you, which is a great program.
Don't forget about the UPS, the United Postal Services is also shipping out free home testing kits as well. Get 4 free.
I did send this PowerPoint to Liam if he wants to distribute it to you guys so you can see the rest of my slides. Really, the only thing I had was resources that we just went over, as well as treatment options such as monoclonal antibodies. I don't usually talk for this long, but I had a lot to say. You know, I am always interested in knowing what kind of barriers people throughout the city face, especially with COVID-19. And so if, you know, you have things that you want to share, I'm willing to hear. And also Liam can always get in touch with me. I have my own personal barriers and I know it doesn't even scratch the surface. So, you know, please keep open dialogue. I'm always happy to hear feedback.
Thank you so much, Emily. And thank you all for attending. And please follow up with me. However you heard about this presentation, please get in touch with any further questions. I will post this onto the PDPH YouTube as soon as I can. And thank you all for joining. We know there is really big inequities around COVID and the disability population, and things change so quickly. So thank you all for joining, and thank you, Emily, and thank you, Emily, for walking us through.
You're very welcome.
Take care, everyone.